Good evening and welcome to the National Audit of Inpatient Falls live launch on the Autumn 2021 Annual Report. My name is Sheshi and I'm the Project Manager for the National Audit of Inpatient Falls. We are very pleased to have you all here with us today. Now, before we begin, just a few housekeeping rules. During the webinar, please feel free to enter questions into the question and answer area or the chat function, depending on which you're able to see as you're on the webinar. And if you're also on Twitter, please join us in the conversation by tweeting us at RCP_FFFAP and hashtag NAIF Autumn 2021 Annual Report. Please note that the webinar will be recorded and it will be available soon after as well. We'll send that in an email. Also to note that microphones will be muted during the first half of the presentation. Now, just a quick overview of the program for the evening. Again, just to note that mics will be muted for the first half of the webinar, but you can go ahead and put in your questions in the chat function or the Q&A function when you are listening to our speakers. So first of all is the welcome and introductions by myself, followed by Julie Whitney, the NAIF clinical lead, who will be presenting on the Autumn 2021 Annual Report. Fran Roberts, the NAIF clinical fellow, will then be talking through quality improvement. And then we'll have Maggie Fielding, our patient and carer panel member, who will be speaking on the importance of involving patients and carers. This will then be followed by the question and answer session chaired by myself with Julie Whitney and Fran Roberts. Now, before we begin the webinar, I'd like to provide some context to the audit. NAIF, National Audit of Inpatient Falls, is one of 3 work streams within the FAP, which is the Falls and Fragility Fracture Audit Program, which is commissioned by the Healthcare Quality Improvement Partnership on behalf of NHS England and the Welsh Government. The program consists of NHFD, the National Hip Fracture Database, NAIF, the National Audit of Inpatient Falls, and the Fracture Liaison Service Database, FLSDB. Although the 3 audits collect different patient demographics, they do all connect by the patient pathway, as illustrated here, with NHFD and NAIF collecting data on hip fracture patients, NAIF specifically focusing on femoral fractures that occur in an inpatient setting where their data is then linked at trust level to monitor the quality of care in hospitals. And then we have the FLSDB, Fracture Liaison Service Database, measuring how fracture liaison services identify, treat, and monitor fragility fractures to help reduce and prevent further fractures. And next, I want to introduce you to the team, putting faces behind the names. So first of all, we have our program manager, Rosie Dickinson, who oversees the 3 audit work streams, followed by Bonnie Wiles, the deputy program manager, overseeing the Quality Improvement Collaborative. Then we have myself, Ninma Sheshi, the project manager, working with the National Audit of Inpatient Falls and the Falls and Fragility Fracture Audit Program's patient and carer panel. We then have Laura Thomas, our project coordinator, who works with the National Audit of Inpatient Falls and the Fracture Liaison Service Database. Then have Julie Whitney, our clinical lead for the National Audit of Inpatient Falls, and Fran Roberts, the clinical fellow for the National Audit of Inpatient Falls. The team, along with input from the specialist advisory group, sets the standards for care, monitors submissions, and write and publish the annual reports. As mentioned earlier, the second half of this evening will be an interactive Q&A session with myself, Julie, and Fran answering your questions, which you can send in through the Q&A panel. Questions that have been answered will appear on the Featured tab. You can also choose to hide or show the Q&A panel by selecting the Q&A icon at the top as shown here. I'll now pass along to Julie Whitney, the clinical lead for National Audit of Inpatient Falls, who will be giving an overview of the 2021 report.
Good evening and welcome to this National Audit for Inpatient Falls webinar. My name is Julie Whitney. I'm the clinical lead for the audit, and I'm going to present an overview of the 2021 report. And this will include what is NAIF, a bit about the 2021 report and what to do with the findings. It's going to be very much a whistle-stop tour, as I've got about 10 minutes to do this. So the National Audit for Inpatient Falls is commissioned by the Health Quality Improvement Partnership, which is contracted to the Royal College of Physicians and has continuously audited all inpatient hip fractures since January 2019 in England and Wales. So how does it work? So since January 2020, all femoral fractures are identified that happen in England and Wales are identified through the National Hip Fracture Database. And one of the questions in the National Hip Fracture Database identifies whether that femoral fracture occurred in an inpatient setting. If it did, then the relevant falls team will complete a set of data on that case. And the data collected on that case will include what happened to the person before they fell over, so the fall prevention activity prior to the femoral fracture, and then also what happened after the fall, so the post-fall management. The bits in bold and underlined are the things that were new in 2020 that were added from the audit process in 2019. And the 2021 report uses the 2020 clinical data, but also data from the 2021 facilities audit. So this is what happens in the National Hip Fracture Database. There's a question asked about where the hip fracture happened. So was the person already on this hospital site? And if the answer is yes, they were on the hospital site, the falls lead is notified and they're asked, was the fracture due to a fall? And if the fracture was due to a fall, it's a NAIF case and the data is collected and submitted. So in 2020, there were 2,052 fractures, femoral fractures, identified on the National Hip Fracture Database that occurred as an inpatient. And NAIF leads reported that 1,357 of these were due to inpatient falls. That means that 29% of fractures reported from an inpatient setting were not due to a fall. So there's some questions about that data, as we'd expect around 5% of hip fractures not to be due to a fall. So one of the key messages from this is that most fractures occur on medical wards. So you can see here, I'm just going to move my face out of the way, that the greatest number of inpatient femoral fractures occurs in medical wards, closely followed by older persons and frailty wards. So I think the really important message from this is that falls that cause hip fractures can happen anywhere, and just focusing on older persons wards is not going to solve this problem, and the approach needs to be wider throughout the whole hospital setting. Around 3/4 of falls were witnessed, but about 13% of falls were occurred when a member of staff was with them. The most common activity was walking, and for 80% of people, this was their first fall. So for most people, there's one chance to get this right and prevent a hip fracture. So looking at the fall prevention activity prior to a fracture, so 3/4 of cases were reported to have had some form of multi-factorial falls risk assessment. And this occurred on average 3 days prior to the fall that caused the fracture. When you dig deeper and look at the quality of this multi-factorial falls risk assessment, you can see some divergence in terms of the completion of particular parts of multi-factorial falls risk assessment. So on one hand, you can see that around 3/4 of people had an assessment of mobility, continence and delirium. Much fewer, just over a third, had an assessment of lying standing blood pressure, and less than half had an assessment of vision. So it's important to do a multifactorial falls risk assessment, but equally it's important to assess the quality of that falls risk assessment and ensure that all components are included. This is particularly important because we were able to look at the prevalence of risk factors in people who sustained an inpatient femoral fracture. And a third of them had evidence of delirium, a third evidence of orthostatic hypertension, and half of them needed to use a walking aid, just less than half having visual impairments and incontinence. So these risk factors are prevalent in people who go on to sustain a hip fracture, and that emphasises the importance of measurements. Care plans that were followed. So it's only useful to do assessment if you're going to do something about it. So 3/4 of cases, the mobility care plan was followed. In nearly all of the cases, the continence care plan was followed. But in just over half the cases, the walking aid that was prescribed was being used at the time of the fall, and just less than half had a delirium care plan documented, if that was indicated, because they had evidence of delirium. So moving on to post-fall management. In terms of post-fall management, these data are tracked against the NICE quality standards 86, statements 4, 5 and 6, which look at checking for injury before moving, the use of safe moving and lifting equipment, and being assessed by a medic within 30 minutes of the fall. And there have been small improvements on 2019 data, in that 71% of people were checked for injury before moving, whereas only 26%, but that is improving, were lifted from the floor using flat lifting equipment, and 62% were assessed by a medic within 30 minutes. Nearly 80% of people had a prescription recorded for analgesia, and the median time to administration of analgesia from the time of the fall was 2 hours. So there are various recommendations. There's a recommendation about data quality. So trusts that have a large gap between actual and reported falls, inpatient hip fractures, and they have 10% fewer that are attributed to a fall, should look at their systems to determine whether this is the case or whether there may be some suggestions of underreporting. In terms of the clinical recommendations, we recommend quality multifactorial risk assessment in all falls, all ward types. Inpatient falls can happen anywhere. To consider using quality improvement methods to improve components of multifactorial falls risk assessment, and also to improve post-fall management. To aim for analgesia within 30 minutes of the fall when a hip fracture is suspected, and to identify where systems and processes can be improved to avoid delays to hip fracture care. In terms of dissemination and leadership, we recommend that the NAIF reports and the real-time data are used in quarterly meetings, in falls working groups, and as drivers for QI projects, and that senior leaders include time for participation in NAIF and related quality improvement activities in the job specs for falls leads, practitioners and coordinators. So what to do with this? So the report is only a report. To improve things, action needs to be taken as a result of the report. So next steps are to identify what the priorities are in terms of improvement in your trust, and to implement that improvement. And those are very simple things to say and not so simple to do. And the methods used for that are quality improvement, and Fran is going to talk to you about quality improvement in more detail. How can NAIF help with quality improvement? I think we can help in 3 ways. There's data, resources, and QI collaboratives. So in terms of data, some of our key performance indicators are now available in more real time. So you can go and look at these online for your trust. And these are at the moment for the post-fall management, but those data, the more data will be added to that. You can look at our resources, so vision assessment, lying, standing blood pressure, patient information, and there'll be more resources coming soon, which include post-fall management recommendations and gaining insight from inpatient falls. The post-fall management will be aiming to minimise harm to patients from incorrect post-fall management, and to ensure prompt access to ongoing treatment and reduce variation in post-fall management. And this will be coming out in the next few months. Gaining insight from inpatient falls is linked to the patient safety incident response framework, and we'll be looking at a hot debrief process and an after action review to improve learning from falls. And the QI collaboratives are currently in progress and being piloted. We'll hope to be able to give you more information about those in future. So thank you for that, and questions to follow, and apologies for my EPR buzzing.
Thank you, Julie, for the those takeaways on the annual report that I'm sure participants will find beneficial in assessing services. If you have any questions for Julie on the report, please enter them through the Q&A session panel. Next, we have Fran Roberts, Clinical Fellow for NAIF, who will be presenting on the quality improvement process.
Hello, good evening. My name is Fran Roberts and I am the Clinical Fellow on the National Audit of Inpatient Falls. I'm also a qualified physiotherapist and work clinically at King's College Hospital in London. I'm going to talk to you this evening about quality improvement and how you can use your NAIF audit data to inform quality improvement projects within your individual organisations. This will be a whistle-stop tour of quality improvement, but hopefully it will get people thinking about ways that you can use QI in your own organisations and maybe be a refresher for people that are already quite well informed about it. So what is quality improvement? I've put the definition up here, but I don't really want to read it out, just because I think for me and my experience, quality improvement is quite simply about improving patient care, and it's the science behind that improvement. It's how we turn fractures and falls into better patient care that's safe. And here we can see a patient mobilising around the ward. And for the eagle-eyed among you, you will see that it's the lady that's on our 2021 audit report. So if my time is correct, I've got about 10 minutes to go through quality improvement with you. The most important thing to start off with is to think about what is your problem. So where are you and where do you want to be? What's the gap? What's missing? What do the guidelines suggest? What does the evidence suggest? What's the gold standard of care that you're striving to achieve within your practice? For this, you can use the NAIF KPIs to help with that. So you can look at how you're performing against these. You can then identify gaps once you're starting to understand your problem and prioritise these gaps about where and how you want to improve. It's really important to not forget the patient in this. They're key to understanding the problem, and they can highlight problems within systems that we as clinicians might well not be aware of. Next task is to find out what your baseline is, and this is really important before moving on to anything else. If you don't understand how you're already performing, then you can't possibly understand whether you've improved or whether an intervention has worked. So having this baseline data is really important. You can use the NAIF KPI data that you can access from the Crown website if you've got access to this, and this will show you how your trust is performing as a whole and also against the NAIF overall. And from this, that might help you to prioritise where your gaps are within the care that you're providing when it comes to inpatient falls. And this is what we're currently doing with some QI collaboratives that the Royal College of Physicians is running. Using their audit data from NAIF to help come up with and formulate aims to improve their care. What's your aim? So once you've got your baseline, you've understood your problem, you've identified your gaps, you need to set a really clear aim. Having a clear aim will focus any intervention that you decide to put in place and ensure that all your data is relevant and necessary, so you're not just collecting data for the sake of it. An aim needs to be SMART, so specific, measurable, achievable, relevant, and time limited. What we don't want is, if you, for example, looking at lying and standing blood pressure and improving how it's recorded, you don't want an aim that's about, I want to record more lying and standing blood pressures. You want to look at that baseline information, think about where you're going, think about where you're at, and come up with a SMART specific aim. Maybe your baseline is 20% of patients have a lying and standing blood pressure recorded, and you want to aim for 50% of them to have a recorded lying and standing blood pressure. How will you measure it? So whatever you decide your aim is going to be, you then need to think about how you're going to measure that improvement, that intervention, and whether it's made a difference. So you're thinking about outcome measures, balancing measures, process measures. Balancing measures are really important here, and they ensure that whatever improvement you are introducing isn't causing a negative effect somewhere else within the system. And they can also be used to help get people on board with your quality improvement project. You will find that not everyone is in agreement with whatever you are wanting to come up with. And a balancing measure can help get them on board. If they're worried that something negatively is going to impact because of what you're proposing, you might be able to measure that and show them that that's not the case. So an example of this in my organisation, we were looking at sitting more patients out of bed, and some people were worried that that was going to increase the number of falls that we were experiencing. So we decided to measure it, and it didn't increase the number of falls that were on the ward by sitting more patients out of bed, which was lucky. Pdsa cycles, so these are the plan, do, study, act cycles, and I think you can't do one Pdsa cycle. You need to do numerous ones. Repeated cycles are often needed to implement successful, sustainable change. And I've just added a diagram here that nicely illustrates what we mean. So you want to plan to do something, so you're planning an intervention. And this might be that you use a driver diagram to help identify the problem, and also interventions that can be used to help achieve your aim. And then it's thinking about which intervention you want to do, doing the intervention, studying it, making sure that you're involving stakeholders, patients, what happened, what worked, what didn't work, and then acting on the results of this to then plan another cycle to help ensure that your intervention and your improvement is making a difference. Has it worked? Really, really important. And the way that you can see whether something's worked, you could use a run chart. As an example of one here. The beauty of a run chart is that you don't have to be a statistician to be able to construct one. I certainly am not. It's just a way of plotting your data over time and ensuring that you're not just reacting to one or two interventions and plot points, and you're actually seeing what's happened over the course of a period of time. This run chart, you can see nicely that around sort of May 2020 there was an increase in the number of contacts, and that was where we implemented our intervention. So this nicely illustrates that the intervention worked, and that's what you can do with anything that you produce. Plot your data over time, produce a run chart, and look whether or not the intervention has worked and been successful. If it has been successful or not, then it's about looking at sort of the sustainability and spread of that. So if you followed the process of QI and use the principles, then you should achieve sustainability. And by that, if someone were to leave an organisation or something were to change, that the intervention that you put into place would still continue, and you would still continue to see improvements. We've all worked at places where I'm sure a project has come in and it's been not necessarily been successful. Someone's left or something's changed, and the intervention has sort of fallen flat. That's what you don't want. And by following the principles of QI and effective Pdsa cycles, you should be able to achieve sustainability. And once that's achieved, you want to then spread whatever you found has worked. So if your intervention for lying and standing blood pressure has made a difference on one ward and shown an improvement, it may well then be that you want to spread that to other wards within your organisation to try and improve their quality of care as well. So final points. Ultimately, it's really important to report all your audit data to NAIF. But for me, the challenge is using this data to inform and improve patient care. There is no point collecting data if you're not going to use it. There aren't, unfortunately, run charts from NAIF, but what you do get are sort of a baseline of where your organisation is against the KPIs, which can then help you to prioritise where you want to intervene with a quality improvement project. It's really important to empower frontline staff to lead this change and involve patients within this as well. And you're going to hear from Maggie next, one of our patient representatives, who's going to talk to you about patient involvement in QI. Thank you very much for listening.
Thank you, Fran, for that valuable information on quality improvement. If you have any questions for Fran, please enter them through the Q&A panel. Finally, we have Maggie Fielding, a member of the Patient and Carer panel, who will be speaking on the importance of involving patients and carers.
I'm Maggie Fielding, and I've been a member of the Falls and Fragility Fracture Audit Programme, or FFFAP, since 2019. I'm going to be talking about the importance of involving patients and carers in order to improve services where falls may occur. FFFAP has 10 patient and carer volunteers. each of whom is assigned to one of the three audit programs, which are NAIF, National Audit of Inpatient Falls, FLSDB, Fracture Liaison Service Database, and NHFD, National Hip Fracture Database. I am one of three patient carer volunteers contributing to the work of NAIF. I see my role as ensuring that the voices of patients and carers are heard by asking the hows and the whys and the whens questions to clarify the purpose of the audit questions and how the results are interpreted. Within NAIF, the patient and carer volunteers look at audit outcomes through a different lens, thus providing the patient and carer view. This aims to contribute to reducing the number of patients who fall in hospital and sustain hip fractures, and to highlight situations and processes that need to be addressed to maintain and improve services. Collaboration and discussion with the wider FFFAP community and external organisations has resulted in the design and production of resources such as the Bone Health Card for the FLSDB, Hip Fracture Guide, a guide for family and carers for NHFD, and the Healthcare Champions and Patients Information Resource for NAIF. The NAIF team has also developed a resource at a glance resource as a way of providing a clear overview for the three main findings of the latest audit. All of the FFFAP resources can be accessed via the Royal College of Physicians website. Communication is key. Over the past 2 years where we have worked remotely, we have worked hard to develop good means of communication, both between the panel and between the FFFAP team as a whole and our colleagues in the wider community. Discussions and conversations within FFFAP have also helped the patient carer panel to become strong and positive resource in the success of FFFAP and the design and delivery of hip fracture services. Open dialogue is essential in changing services for the better, as are events such as today's session, which focuses on patient and carer involvement in NAIF. It provides a forum for the exchange of ideas on NAIF and how the audit can contribute to identifying and implementing service changes that lead to service improvement. Patient and carer involvement can be very powerful. Within FFFAP, we have been fortunate in having a stable and well-supported patient and carer panel, but we are very aware that it is often difficult to recruit individuals who represent all sectors of our society. The panel contributes to efficient and productive services and ensures that both service providers and service users benefit. Raising the profile of patient and carer involvement within the healthcare setting is very important, as it makes sure that the many successes of these types of collaboration are made known, both within the individual organisation and the community as a whole. Advertising and surveys do work, but information and communication is the key to making the public aware that their input and opinion could help ensure that services are designed to embrace the needs of service users. I do hope my brief outline of patient and carer involvement within NAIF has been of help to you and provided you an overview of patient and carer involvement. I'm aware that many of you already invite patients and carers to join your projects, but if you have not done this so far, please give it a thought. The Royal College of Physicians website has information that will help you consider patient and carer involvement as a way forward for your organisation. I fully enjoyed my time with the patient carer panel. I've learned a lot, and I have a better insight in how services for people who've suffered fractures work. The whole experience has been positive, and I believe that the work that we have done has driven improvement across numerous services.
Okay, great. Thank you to Maggie for sharing the importance of patient and public involvement to help drive improvements in services. The patient and carer panel has been a valuable asset to the FFFAP programme. For those that have just joined us recently, good evening, and thank you for joining us this evening for NAIF's first webinar on the Autumn 2021 Annual Report. We're now going to go into the question and answer session. chaired by myself with Julie and Fran. So if you can go ahead and share your questions, we will start to answer those. Okay, so the first question we have is from Gillian McKee. Is there any guidance around what analgesia is best, post falls and fracture analgesia? So I think I'll give that to Julie to answer, right?
Yeah, that's right. Thanks, Ninma. There is some guidance in the for hip fracture analgesia in the NICE guidelines for hip fracture management, and those guidelines suggest that a patient should be assessed for pain immediately. But the NICE guidelines are centred around fractures that present to the emergency departments, but there's no reason why that shouldn't apply to inpatient settings. NICE suggests initially starting with paracetamol and then reassessing pain, and then providing opioids if opioids don't provide adequate pain relief. And then the next stage in the analgesia ladder is to consider nerve blocks. Nerve blocks need to be administered by an anaesthetist and should not be used to delay surgery, but are associated with good outcomes where pain is a issue preoperatively. I think that's probably my answer.
Okay, great. Thank you very much. Thank you, Gillian, for that question. The second question we have for Fran, which is from Gemma O'Driscoll. It asks that recently they've gone on to EPR at the end of last year. Prior to that, we had a thorough MFRA. She just wondered how other trusts have managed in uploading a new form to the electronic system so all members of the MDT can contribute.
I think this is actually really quite challenging, Gemma, actually. Certainly for the trust that I work at, we have EPR, and our multifactorial risk assessment on that is usually completed by the nursing staff, and the different disciplines then complete their own risk assessment aside from that. And I think we as a trust are trying to look at that from a bit of a quality improvement perspective in terms of trying to improve how we are completing multifactorial risk assessments. And I think the sort of getting it right first time work that we're doing with some trusts, piloting different ways and innovative ways of trying to ask sort of what's happened with the fall and actually discussing it at handovers, and I'm looking forward to sort of the results of those pilots, that we can then sort of spread the good work that's had. But it is challenging, and I would say there isn't I haven't got an answer, certainly from my experience.
Okay, awesome. Thank you, Fran, and thank you, Gemma, for sharing, asking that question. Third question is from Catherine, and she asks, in a pressured NHS, COVID has meant family and visitors have not been on the wards giving relatives basic care, fluids and feeding, etc., but also giving background information re patients. Has there been any impact on number of falls compared to prior to COVID times? And I'll hand that to Julie.
Thanks, Catherine. That's a really interesting question, and I think we all appreciate the difference that COVID has made to lots of our clinical practice. Back in 2020, we did a very, it wasn't very sort of scientifically robust, but we did a survey of some of our falls coordinators as to what they felt had happened to falls rates in their hospitals as a result of the first wave of COVID. And it was quite a mixed picture, actually. So there were some trusts where their falls had increased, and some trusts where the falls had actually decreased in COVID because there were fewer, although they had more people with COVID, there was actually a reduction in the number of inpatients because of social, sort of having to increase distance between patients, and also because other patients weren't coming into the hospital. What people noted was that there were various things relating to donning and doffing PPE and oxygen and people being stuck in bays with doors closed that increased the risk of falls, they felt.
and also that there were quite a lot of younger people with severe COVID who were falling because they were delirious and quite unwell. We didn't repeat that again in 2021 because we thought people had enough on their plate. But what we will be able to look at in the 2021 data is, and we're planning to do that, is to look at comparing people who had COVID during their inpatient stay and sustained a fall to those who didn't have COVID during their inpatient stay. So we should have a little bit more data on that, but I'm afraid I think it's quite a mixed picture in terms of what's happened with relation to falls. In the first wave, our data didn't say much about the impact of not having relatives. I think that's begun to bite a little bit more in 2021, where we've really noticed the difference of through the long haul of not having relatives there, and where the sort of burden of really sick patients has changed, hasn't it? And it's just that people aren't relatives aren't allowed to come in. I hope that it probably doesn't answer it very adequately, but I have some slides somewhere which could be shared around the presentation of the data from last year, from 2020. Sorry, not last year.
Awesome. Thank you very much, Julie, and thank you, Catherine, for that question. We've got some more coming. We do have a question from Jonathan that has asked, when are the trust level reports now available? So yes, we can answer that. Trust level reports for the autumn 2021 reports have actually now, they should be available to all participating trusts on the web tool. So that should be on the left-hand panel when you log in. If you have any questions in terms of accessing that, please feel free to email us at falls@rcp.ac.uk. Again, that's falls@rcp.ac.uk. Next question I have is from Claire, asking, are there plans to roll this out for other injuries, i.e. head injury? And I share that with Julie.
Thanks for that question, Claire. I'm really keen to be able to do that. I think people have recognised the importance of NAIF, but also the limitations that it's only looking at hip fracture. One of the things that will have to happen for it to increase the number of injuries that become cases is to change the structure slightly, because at the moment it relies on the National Hip Fracture Database identifying all the cases. If we were to move to head injuries and to other fractures, it would sort of change the setup of the audit, in that the NAIF teams would be opening cases and entering cases. So it's something that we are looking at and are keen to pursue, but it won't happen in the next year. We are not contracted to do that by HQIP. But we are having discussions about what can change in the future.
There was a thumbs up, so I'll assume that was a happy response from Claire. Thank you, Julie. Next question I have is from Louise Lodge, asking, can someone explain the process for identifying the gap between reported and unreported falls? I really struggle to understand this process and feel pretty confident that staff report pretty much all falls. We have only ever found one unreported fall during our investigation. Thanks. Thank you, Louise.
Do you want me to answer that? I mean, it sounds to me like, Louise, you're doing what that is it is a sort of slightly subjective process, in that what you're trying to do is gauge an idea of whether there are any unreported falls happening in your trust, sort of in a sense through the grapevine, really. So obviously you only have what goes into your Datex or other reporting systems as the reported falls, and there are some methods that can be used, and there in our web tool there are some references to those as to how to employ techniques to look at how many falls may be happening that are unreported. One such method is, sounds like you're doing that anyway, is popping onto the ward, and doing a sort of quick, sort of brief survey and asking people, in the last, 3 months, have there been any falls that you're aware of that weren't reported, and to get an idea of whether that's happening and how often that's happening. And obviously that has to be undertaken in an environment and a context where people feel comfortable with sharing that kind of information, and there's not going to be any repercussions. In terms of the what we've mentioned in NAIF that I didn't explain very well in my presentation, that's the difference between the number of inpatient hip fractures that are reported for that trust and the number of inpatient hip fractures that are attributed to a fall. And we'd expect about 5% of hip fractures to not be due to a fall. So that's why we're suggesting that trusts who have a higher proportion of inpatient hip fractures that are not attributed to a fall, just go back and have a look at those cases. It may be that it's completely above board, and there was they were pathological fractures, or actually the fracture seemed to happen before the person came into hospital and was only identified later on in the admission. And that's and you may find that there are good explanations for all of those, but if there are quite a high rate of those, it's worth just going back and checking notes to see how that hip fracture occurred and whether there was a fall that just didn't end up getting put into the reporting system.
Thank you very much, Julie, for answering that, and thank you, Louise, for that question. The next question I have comes from Rachel, saying a high proportion of inpatient falls in the acute ward environment involve patients living with dementia. Is NAIF looking to do any work or make any recommendations in the future for reducing risk of falls for this high-risk group of patients? Anything around meaningful activity, occupation, or meeting unmet needs which increase risk of falls? Fran, oh, Julie, you're on mute, sorry.
Sorry, I can't see myself on mute. I don't know if Fran has something to add to this, because Fran does a lot of work on the in the clinical setting with people with dementia. It is a real challenge, isn't it? So I've done lots of my research in falls prevention in people with dementia in community settings, in care homes, in hospitals, and I think the added issue of delirium in hospitals is a real challenge. One of the most promising bits of research looking at falls prevention in hospitals actually didn't come from a falls prevention study. It came from a study looking at for the management and prevention of delirium. So I think lots of the methods that are used to address delirium are likely to be effective at preventing falls. I think that there isn't a huge amount of evidence in the acute setting, but I do think what you've said around meaningful activity and occupation and unmet need is really key. I like to think of the Tom Kitwood flower. I don't know if any of you are aware of the person-centered care flower that looks at occupation, identity, attachment, inclusion and occupation, or I said occupation again, I can't remember, but looking at the comfort, sorry, is the other one, and looking at actually making sure that those unmet needs are identified in people who are unable to verbally express them, and addressing those. And I think out of all of those, occupation is probably on a lot of in a lot of inpatient settings is lacking for people, and meaningful occupation, so occupation that is is an activity that is suitable to somebody's level of ability to participate. And Fran, have you got anything else to add?
No, I suppose it's kind of also thinking outside the box in terms of other areas, other people that you can use to help in terms of managing patients with delirium and dementia, and certainly we've started to look at volunteers within the organisation that can come and spend more time with patients, because we've noticed certainly with COVID and delirium especially, increased numbers of patients wandering and falling as a result of that, and that there's just not the staff around to be either supporting them in cohorts or one-to-one. And so I think for us, it's been around looking at those sorts of things, and then within your organisation as well, if you're identifying that as a problem, to sort of then come together as a team and sort of work out if there's any ways to help reduce that.
Great, thank you, Julie and Fran, for answering that question, and thank you very much. I think that was Rachel for sending that question in. Next, I have a question from Caitlin asking, oh, hold on a minute before hi everyone, and many thanks for the session. What is the strength of recommendation of how is harm level attributed to fractures? Some trusts deem them severe harm, some moderate harm. Is it best to review all incidences case by case?
I'll answer that. Thanks, Caitlin. So our recommendation is that a hip fracture the harm attributed to hip fracture should be severe harm. What we found when we first started doing this, that there were trusts who were taking the approach of we will make an individual decision for each patient, and suggesting that if the patient seemed to be sort of back on their feet and walking reasonably well, then they hadn't experienced any harm, and were attributing some hip fractures as no harm or minimal harm. The consensus among the team that contribute to NAIF and the advisory group that contribute to NAIF is that an injury that requires surgery and an injury that has a high mortality rate. So in inpatients, 12% of people die within 30 days of a hip fracture. I think that has to, even if the patient has a good outcome and doesn't have a decline in mobility and can go back to their usual residence, I think that still counts as severe harm. It's a significant fracture that requires surgery, that will require rehabilitation, a period of recovery, and has a high risk of mortality.
Thank you very much, Julie, for answering that question, and thank you, Caitlin, for sending that question in. Next question we have is from Eloise, and she's asking about the e-learning platform that we have. So just for context for others, that is for the Full, Safe and Careful, which was previously hosted by us. So that should be, just to answer that should be available in the next month. We will share communications once that's available. So if you're not signed up to our newsletter, please go ahead and sign up, and you can do that by emailing us again at fools@rcp.ac.uk, and we'll be able to sign you up if you're not already registered with the audit, and we can let you know when that is available. Okay. Next question I have is from Lorna Knight, and she is asking, I am junior to full safety lead to my trust and wanted to know other areas actively using the hot debrief form, and do you find the information useful for completing the data? So I think I shall give that to Julie. Okay, great.
Yeah. Thanks for people who are using the hot debrief form. So the hot debrief and the after action review are still, we're still in the pilot phase of that. So that was developed by a task and finish group working with NAIF. We had some pilot sites that we're using that. Some of the pilot sites were early adopters for the Pdsa project with NHS England. We had conducted a survey of the people who had used that, had some feedback from them, and we're in the process at the moment of completing some focus groups with trusts who have been piloting the hot debrief and after action review processes. The aim for this is that we will be responding to the feedback that we've had and probably making some tweaks. We've had a lot of positive feedback about the processes. I think some of the less positive feedback about the hot debrief is that the number of sheets of paper it's on. So I think some of the tweaking is going to be around sort of reducing the size of that, unless we get sort of lots of feedback to the contrary. And so what we're hoping is that when we finish these interviews and analyse these interviews and focus groups, we'll have a refined version of the hot debrief and after action review to be able to share with you. We welcome any feedback on that. So if you know, please do get in touch with us at the or Ninma on the Falls on the NAIF email, if you'd like to feedback on your experiences of using the hot debrief or the after action review, because the more feedback we have, the better in terms of having a final product that really works for people. Thank you.
Awesome. Thank you again, Julie, and thank you, Lorna, for asking that question. Next question I have is from Siren, but I hope I pronounced your name correctly, and that is for Julie. It asks, any solution to get more sample to a community NHS trust for the NAIF? We rely on acute trust to enter data to NHFD accurately. We had only one submission each for 2020 and 2021. We know we had more hip fractures from our DATEX system. However, we have not received notification. We have contacted at least 5 acute hospitals in the wider area. Does the acute trust need more training on how to do the initial submission to NHFD?
Thank you. We are aware of this problem. So there's a bit of a process that happens. So first of all, the NHFD, whoever is completing that, needs to recognise that the fall has happened in an inpatient setting. So if a person has fallen in a community setting and come in through the emergency department, I think sometimes they just get attributed as an emergency department attendee fracture, and so it's not recognised that they're an inpatient. There's then another process that it needs to go through, which is that it gets allocated to the NAIF team in the acute hospital, who then have to sort of make some inquiries and work out where this fall actually happened if it didn't happen in the acute hospital. I mean, my feeling is, generally speaking, the NAIF people are reliable and do complete the complete these things correctly. We are working on a solution to that. So we are currently working with the Crown database that collects all your data around having an option for trusts to open their own case when they know that they've had a hip fracture. And ideally, that would there would be some way of aligning that with the record in the NHFD, and then we'd start to get a really good idea of how many of those fractures are incorrectly attributed to a community hip fracture rather than an inpatient setting hip fracture. So bear with us, we are working on it.
Great, thank you, Siren, for that question, and thank you, Julie. Next question is for Fran. It's from Linda asking, deconditioning and weight gain during COVID seems to have increased the number of inpatient falls. Will this be considered in the data collection going forward over the next 12 months?
It's quite an interesting question, and I think one that is maybe not just about NAIF. I don't know whether there is any data actually around whether, obviously we know that patients are deconditioning, but whether there's an actual link to deconditioning, weight gain and falling. I suppose it kind of comes back to that earlier question that Julia answered about how, you know, NAIF and number of falls and whether it's increased with COVID, etc. And that will highlight in the report, and we could potentially attribute those numbers to COVID, as that would have happened in that time frame. But that sounds like more of a thing that maybe locally within your own organisation to interrogate that data and to look a bit more closely at that fall and why those patients were falling, and whether there is a link to deconditioning, and whether you've got other outcome measures that could then come to that conclusion that deconditioning has led to more inpatient falls at your organisation.
Great, thank you, Fran. I have another question for you, and So thank you, Linda, for that question. Next question is from Natalie, and she's asking, MFRA recommends having a visual assessment when someone has been admitted as being acutely unwell. This is sometimes difficult to achieve. Is it enough to ask someone when their last optician appointment was, ensure they have their glasses, and recommend visiting the optician, or should it go more in depth than this if there is no acute visual problem?
I think definitely talking from experience, the visual assessment is always one that I often either forget to do or that my team forget to do as well as part of their multi-factorial risk assessment. I think it is, as long as you're asking about vision, that's really important, and you're acknowledging that vision might be a problem for that patient, especially with our patient population over 65s, then usually, yes, vision plays a massive part, and it is one that is overlooked. The bedside assessment tool that the RCP have produced is a great tool, and it is actually really quite quick. If you've got a very acutely unwell patient, then absolutely you can only do what you can do at the end of the day. But I suppose we would recommend trying to do as much as you can in terms of a visual assessment as possible. And that tool is really useful, and certainly my team like using that because it's quite quick and easy.
Awesome, great. Thank you very much, Fran. And next question we have is a second question from Caitlin. It's asked, with regards to the facilities audit, the fall rates increase or decrease? It is increasing, as it seems to have asked about falls rates rather than falls per 1,000 occupied bed days. Interestingly, while there was a decrease in the rate of falls, fall per 1,000 bed days increased. Did this happen to anyone else? And it also continues on, sorry, there's an extension to that. How good of an indicator is the fall rates compared to the falls per 1,000 bed days indicator?
Caitlin, I might need to ask you to clarify that a little bit, because when we've looked at falls rates, we've always looked at the rate. So it's the rate of falls per 1,000 bed days. We actually haven't been publishing that data purely because the falls data, there are issues with the reliability of falls data, and particularly with the idea of trusts comparing themselves to other trusts on their rates of falls per 1,000 occupied bed days. It would be very easy for a trust that underreported falls to look better on a if they were looking at their falls rates, and then a trust that was good at reporting their falls, which we encourage, and we want people to report their falls. There's also going to be regional differences. So a hospital in central London, for example, where about 15% of the population are over 65, is likely to have a different demographic in their inpatient setting and a different falls rate to a hospital in somewhere like Bournemouth, for example, where their proportion of over 65s is significantly higher, or a community setting, for example, where the majority of people in intermediate care beds, for example, are going to be older and at risk of falling, and engaging in rehab, which increases your exposure to falls. So I think we have been encouraging people not to focus on their falls rates per 1,000 occupied bed day in sense of benchmarking, so in the sense of looking at how they're doing compared to other people. And we constantly get questions about what is the national average at the moment, and our answer to that is the national average is not important. It's what was your average 3 months ago, what was your average 6 months ago, how is your organisation changing, and that's the important thing to look at. So it's to look to compare yourself to yourself in terms of your falls rates per 1,000 occupied bed days. If your question, Caitlin, is relating to the facilities audit, so there are some honing down questions this time that some of you may have found yourselves engaging with in the last few weeks. that are asking about for some more detail about what you've been doing when you analyse your falls per occupied bed day. So it's been looking at you know, what changes there have been if you're using run charts or SPC charts to look at your rates of falls. And those rates of falls might be per 1,000 occupied bed days. You might measure rates of falls in a different way. So you might measure it for fewer occupied bed days. I think that the gold standard for inpatient falls rates is to measure it per occupied bed day. The data that we present in the national audit is the rate of inpatient hip fractures per occupied bed day. And because they are lower, we present those as per 100,000 occupied bed days.
Great, thank you very much for that. Just to let everybody know that the resource that Fran had mentioned, the Lookout resource, has been pinned at the top of the chat, so you can look at that there. Our Laura has shared that for you. Great, okay, and the next question we have is from Christina for Fran, asking, sorry, hold on a minute, I've lost it. Do all trusts do an annual walking aid audit?
I thought I'd take this one because I found it quite an interesting one, Christina, because I just wondered what the walking aid audit would be. Certainly at my trust, we don't do a walking aid audit as such, but if it's sort of in relation to the multi-factorial risk assessment, and if your numbers are low in terms of your patients having a mobility aid, then that sounds like a really good idea for a bit of a quality improvement project, rather than sort of a generic audit to find out why it is that patients haven't got their walking aid with them, and what you can do as a trust or ward to improve that. And I think that then comes back to Julie's earlier point there, where it's less about what everyone's doing and more about what you as a trust are doing, and how you're improving your sort of compliance to the risk assessment and to improve your inpatient falls. But if anyone else on the chat or on the call does do an audit for walking aids, then maybe pop it in the chat, and then Christina can catch up with you about what that looks like.
Okay, Christina has.
Shall I answer? Shall I just add to that as well?
Mm-hmm.
So it's on. There's a question about it on the facilities audit, because Christine, we don't know what people are doing. So we've had a question on the facilities audit for the last few years that has been: does your service have 7-day access to walking aids, or something along those lines? And so what we thought we'd do is just add a question there about whether if services were doing that, whether they'd audited the actual access to walking aids or not. So if you don't do one, it's absolutely fine to tick no. And if 100% of people have ticked no, we'll know that actually no one's doing them. If some people have ticked yes, then actually we'll know who those people are, and we'll be able to get them to share what they've done and share among the community what works well.
Awesome, thank you, Fran and Julie, for answering that. There's a question that Claire has put in, asking, are there plans to recommend how to assess for hip fracture, as many are missed or delays occur? We have devised, and she's mentioned that they've devised their own, which she'd be happy to share, and I see that some people have responded to that, so just wanted to mention that. But Julie, would you be happy to speak to that, please?
Yeah, Claire, are you referring to hip fractures that get missed because of inadequate checks for injury and so the hip fracture isn't noticed at the time of the fall? Because we've certainly had lots of feedback. Thanks, Claire. Very fast response. We've certainly had a lot of response from people saying that they're concerned about that. So we have a really nice, helpful rubric on how to do a multifactorial falls risk assessment, but we did realise that actually there's very little guidance in terms of how to support people with the competencies to be able to do post-fall checks and determine how to assess for any injury post-fall. We've had a task and finish group working on that within NAIF for probably the best part of the last year. It's been a little bit like choosing a new pope. We're going to put some white smoke out the window once we've finished it, but we're about to pilot that in a few trusts. It's been we're just sort of working on what competences are required. It's been a more complicated process because we want to make the resource useful for not only acute settings but also community settings and mental health settings where there may not be a medical, a medically trained professional on site at all times. So we need something that works for all settings. Once we've done a bit of pilot work on that, it will be ready to share. But we'd really welcome, if sharing your work with us as well, so that so we can make sure we haven't missed anything. We did request quite a bit back when we first started this for people to be able to send us in what they'd done, so we could start at that's where we started from. So please do send stuff in while we're still working on this.
Great, thank you very much, Claire, for sharing, and thank you, Julie, for answering. The next question I have is from Lorna asking, I'm in the process of completing the facilities audit. Is there a guide to completing it? What I will say is that my colleague Laura will share a link to where you can download the pro forma, but also I guess I can just leave this question a bit open. There isn't a guide, but if you send us an email into thefalls@rcp.ac.uk, we'll be happy to help you answer any questions that you have and help make that a smoother process. And just a reminder, the deadline for the facilities audit is the 31st of March, but again, contact us if you need any support for that. The next question I have is from Jacqueline, for Julie, asking, just going back to the grade of an incident of a patient with a neck of femur fracture, I believe, we recognize that it is a severe harm injury and grade as such in relation to the injury on our incident management system. However, when we have completed a review and if we find that all care was appropriate and in place, we downgrade the incident. We do keep the grade of the injury as severe harm, but look at it as if we could have done something differently as a trust. Is this something that could be considered?
So that's thanks for that question, Jacqueline. That isn't something that we've considered because the severity or the sort of attribution of harm is the attribution of harm to the patient. It's not an indication of the level of care. It's what happened to the patient and the consequence for the patient. It's what we're using at NAIF is what NHS England have suggested is good practice. I'd be reluctant to change that. I will discuss that with our patient panel, but my feeling would be that we look at what the level of harm that is experienced by the patient. It's not, when you're putting that category up, it's not about the level of negligence or the level of poor care. Patients can experience harm when their care has been, completely, of a good standard. But it's the patient has still experienced harm, and that is the patient's experience.
Great, thank you, Julie. Okay, so thank you, Julie, for answering that question. Okay, we just have one more question because I realize we are about rounding off in a couple of minutes. So I'll just take this final question and then we will wrap up. But if there are any other questions, please feel free to email us at falls@rcp.ac.uk and we'll get back to you and respond to any queries that you have that might be about this presentation or anything about the audit. So this question is from Ayodele Ayeni. And he asks, in a mental health trust, it is sometimes challenging to assess patients for injuries before getting up, as some will want to get up despite being in pain. What do you suggest?
Thank you. That's another great question. It does happen. I did an audit a while back of pelvis and hip fractures that had come into our hospital from care homes. And a reasonable proportion of people had got up without even their fall being noticed by anyone and started walking around again for some time before staff noticed they were limping. So we know that people do get up on hip fractures. If somebody's trying to get up, I don't think you can stop them. Obviously what's going to happen is that when you go to write your report, that is, it's not going to get attributed to to ideal quality standard care, is it? Because the person hasn't been hoisted up with a flat lifting equipment, and they may have had a check for injury, but they've decided to or they've got up and tried to walk. Because of the small numbers in NAIF, we want you to approach it in a qualitative way. So some of what you'll do with your data is go back and look. So if you go back and look at why you have performed poorly, for example, in one of the quality standard 86 statements, you might want to go back and explore those. In small trusts, you won't have that many hip fractures, so you can afford to do that and go back and look at the cases. And actually, if there's the odd case where that happens, that's there's not much you can do about that. But if it's probably not going to be every patient that you have that has a hip fracture where that's going to occur, but these things will happen from time to time.
Great, thank you Ayodele for that question, and thank you Julie for answering. Again, thank you everybody. I'm afraid we can't answer any more questions as our time is up. But again, thank you for joining us this evening. If you have any questions that we weren't able to answer this evening, feel free to contact us at falls@rcp.ac.uk. In relation to the audit. Again, a reminder that the facilities audit ends on the 31st of March. That also includes data from the 1st of January to December 2021. So that's, again, the 1st of January to the 31st of December for the year 2021. Again, if you have any questions, let us know. Thank you for joining us this evening, and we hope you have a great remainder of the evening. You take care. And the recording will be available and we will share that in an email. Take care. Thank you again, Julie, Fran and Maggie and Laura. Bye.